intracranial vascular lesions to be followed by posterior fossa imaging, inshallah. These are the topics we would like to handle. What about the aneurysm, arteriovenous malformation, the cavernous hemangioma or the cavernoma, the developmental venous anomaly, the vein of Galen malformation, and finally the Moya-Moya disease. You know that intracranial aneurysms are a frequent finding on the clinical practice, and this is the incidence about 1 to 10%, and the overall risk of rupture is about 2%. We have many types of aneurysms, like the congenital, the traumatic, the inflammatory, and sometimes we have neoplastic aneurysms, which are called oncotic aneurysms. These aneurysms result from the erosion of the vessel by a malignant tumor nearby, with the resultant aneurysmal dilatation. Then the three main types of aneurysms are the saccular, which is sac-like, the fusiform aneurysm, which has no neck, then the dissecting aneurysm. The incidence of solitary aneurysms is about 75% compared to 25% of multiple aneurysms. Actually, the role of imaging is to identify the size of the aneurysm, the neck width, the location in the circulation, if it contains internal thrombosis or not, if there is a perianeurysmal leak, or if the aneurysms are multiple, and the biggest one should be identified because it is the most likely one to rupture. The clinical picture of aneurysm in itself is usually silent unless it is related to a major structure. If an aneurysm related to a nerve, this will result in neuralgia, commonly the oculomotor nerve, and the trigeminal nerve will suffer from this. Then if the aneurysm is ruptured and the patient developed subarachnoid hemorrhage, the most common sign or symptom is the sudden onset of severe type of headache. And sometimes neck rigidity, sometimes loss of consciousness, sometimes nausea and vomiting, or seizures. Third nerve palsy is a sequelae of posterior communicating aneurysm. 15% of the aneurysms are located in the posterior circulation. 50% of these 15 occur at the tip of the basilar artery, and this is also one of the common lesions seen in the clinical practice, where you got the homogeneously enhanced lesion in the midline anterior to the bones, where the basilar artery is present. Then you may use the facility of multi-detector CT and reconstruct the images so that you are able to see the neck of the aneurysm and the exact site of origin. And also you can see the inside of the aneurysm if there is a clot or not. The saccular aneurysm is known as perianeurysm, which is like a grape. And the aneurysms, as I have mentioned, 85% occur in the supratentorial or the anterior circulation, and 15% occur in the posterior circulation. The CT findings of an aneurysm, if you do not inject contrast material, the aneurysm will show faint hyperdensity, sometimes with marginal calcification, and if there is an associated subarachnoid hemorrhage, you can see in the scan. But if you inject contrast material, the aneurysm will show homogeneous post-contrast enhancement. Then if you are asked in the exam, what are the findings in the CT scan of a patient known to have an intracranial aneurysm? Then you should say that the aneurysm itself will appear slightly hyperdense in the pre-contrast study. Marginal calcification can be seen. If you inject contrast material, you'll see homogeneous enhancement. If there is some bleeding from the aneurysm, you can detect a subarachnoid hemorrhage. Then aneurysm by MRI will show signal void appearance. It will appear black in all MR images, in the T1, in the T2, in the flare. And if you inject contrast material, it will appear black also because of the contrast enhanced blood will flow rapidly inside the aneurysm. The only way to see the aneurysm itself is by MR angiography. Then you can identify the sac with flow inside the aneurysm. The fusiform aneurysm is by definition the aneurysm with no neck. It is just a fusiform dilatation of a segment of an artery. And you know, the aneurysm with the neck is clamped by metallic clips to occlude the flow inside the aneurysm, and this is the treatment. But this fusiform aneurysm is not suitable for clamping. It is surgically excised, or some way of intervention can deal with this type of the aneurysm. Then giant aneurysm is that aneurysm above 2.5 centimeter, and it represents about 25% of all aneurysms. And this aneurysm is liable to internal thrombosis and is liable to rupture. And also because of the size, it can produce symptoms. This is the pre-contrast CT scan showing hyperdensity in the aneurysm, and the CT angiography showed the patent lumen enhances with contrast material, and the thrombosed lumen does not enhance with the contrast material. Then you should identify in your report or in the exam whether if the aneurysm is partially thrombosed or not. And if you look here in this CT scan, and you got this is a pre-contrast study, and you got a marginally calcified lesion, and this lesion was interpreted to be a meningioma. But after MRI, then you can see the most pathognomonic feature of an aneurysm, which is the whirly appearance due to turbulence of flow inside the aneurysm. This is an extremely characteristic finding, which is clearly seen in the T2 weighted images. And this is what I mean. There are whirly artifacts due to the turbulence of flow inside the lumen of the aneurysm. It will result in these circles of artifacts, and this is lead you to the diagnosis of an aneurysm. The patent lumen will show signal void. The thrombosed lumen will show mixed signals according to the age of the thrombus, if it is acute blood or subacute blood or chronic blood. Perianeurysmal edema is seen, and sometimes you got perianeurysmal hemorrhage if the aneurysm is leaking, like this one. There is an aneurysm here, and you can see the leak of contrast material and of blood in the perianeurysmal area, as well as in the subarachnoid space. What are the findings that can suggest that this aneurysm will rupture? Number one, if the aneurysms are multiple, it is the largest one which is prone to rupture. Number two, if the length of the aneurysm to the neck of the aneurysm, the size of the aneurysm to the size of the neck of the aneurysm is more than 1.6, meaning that the neck is wide, then there is a possibility of the aneurysm to rupture. Increased volume of the surface area of the aneurysm, angulation of the aneurysm, presence of focal blebs in the wall of the aneurysm. Then you cannot predict from images that this aneurysm will rupture, but you should diagnose from images if the aneurysm has ruptured. Rupture of the aneurysm will be associated with perianeurysmal bleeding, and then extension of the bleeding into the subarachnoid space. You remember that the most common cause of subarachnoid hemorrhage is trauma. Then the causes of a spontaneous subarachnoid hemorrhage include rupture of an aneurysm, rupture of an arteriovenous malformation, moya disease, and the vasculitis. The CT angiography of this case showed the lumen of the aneurysm, and the rest of the surrounding hyperdensity represents the bleeding, as well as the extent of the blood in the supracellular area, as well as in the basal cisterns. This is a giant aneurysm, and in the aneurysm, this arrow points to mural calcification within the aneurysm itself, the aneurysmal wall. Then in the pre-contrast study, you see a hyperdense rim around the aneurysm, and this represents the blood outside the aneurysm. And the hypodense rim represents edema around the aneurysm. On the contrast enhanced scans, you got enhancement of the patent lumen, and this is the patent lumen, and this is the leak of the aneurysm in the perianeurysmal area. And also seen in the CT angiography, the patent lumen is enhancing while the perianeurysmal leak is not enhancing. This is bleeding. Then we came to the arteriovenous malformation, which is a group of vessels that are directly connected between the artery and the vein without the bus or to the capillary level. If you are asked about the possibilities that you can see in a patient with arteriovenous malformation on CT scan, and you say the CT scan may appear absolutely normal, as you can see here in the pre-contrast study, or you may got hyperdense serpiginous structures, or you may see calcification, or you may see intracerebral hematoma secondary to bleeding, and if you inject contrast material, you will see serpiginous pattern of contrast enhancement. The clinical presentation will include headache, epilepsy, and focal neurological symptoms. I mentioned yesterday, if you see bleeding in an abnormal location and in a younger age, then you assume that this bleeding is due to an underlying cause. And I mentioned that the most two common causes of bleeding in young age and abnormal location are bleeding cavernoma and the bleeding arteriovenous malformation. Arteriovenous malformation can be seen by MRI and can be seen by angiography, but the bleeding cavernoma cannot be seen at all by any imaging modalities, neither by MRI, neither by angiography, because whenever the bleeding cavernoma bleeds, it will be masked by the hematoma. But the arteriovenous malformation can be elicited by MRI or by selective angiography. And this is the appearance of an arteriovenous malformation by CT, pre-contrast and post-contrast. You got too many vessels, and these vessels are serpiginously enhanced. they exert little mass effect and they are not usually surrounded by edema unless there is bleeding from this vascular malformation, then edema will be seen. Actually, on imaging at the time, we tried our best to see the feeding vessel of the arteriovenous malformation and the draining vein. But actually, this is the rule of angiography, and it is performed very well whenever you are going to treat this arteriovenous malformation by embolic material. Then our role on imaging regarding the arteriovenous malformation are these. Number one is to detect the lesion itself and to say its possible location and size. Then you detect if it is bleeding or not. Then you detect if it causes hydrocephalus or not. And you see that if it exerts a mass effect or not. Then you look in the area around for ischemic changes because shunting, direct shunting of blood from the artery to the vein without passing through the capillaries will result in ischemic tissue in the vicinity of the arteriovenous malformation. Then you report this clearly in your report. But if you see a lesion like this with serpiginous high signals in the pre-contrast high density, in the pre-contrast CT and calcium, without significant mass effect on the ventricle, you assume that you are dealing with an arteriovenous malformation. And you can see the vascular malformation on MR. But if you want to see the feeding vessels and the draining veins, it is the job of angiography. And we are no more trying to do this in the reports unless they are clearly evident. You see the feeding artery is very big and the draining vein is also very big, then you may say that this artery is the feeding one and this vein is the draining one. But in this vascular malformation, for example, it happened that it is supplied from the posterior circulation through the posterior cerebral artery and from the anterior circulation through branches from the middle cerebral artery. These informations cannot be obtained from the imaging, regular imaging. Then you have a form of arteriovenous fistula, which is the carotid cavernous fistula. The internal carotid artery coming from the neck, passing through the carotid canal in the skull base, then getting inside the cavernous sinus. Then after that, it emerges from the cavernous sinus and divide into the middle cerebral and the anterior cerebral. During the course of the artery inside the cavernous sinus, there may be an insult that resulted in direct communication between the internal carotid artery and the cavernous sinus. Then the pressure in the sinus will be increased and the sinus size will be increased and the veins draining inside the sinus will dilate because of the high pressure inside the sinus, which prevent the regular venous flow. The best one is the superior ophthalmic vein. Then if you see that the cavernous sinus is enlarged, homogeneously enhanced, and the superior ophthalmic vein is markedly dilated, then you know that you are dealing with the carotid cavernous fistula. In the literature, they divide the carotid cavernous communication into 4 types, but this is not your job actually. I say this because sometimes you can see that the cavernous sinus is not that big and the superior ophthalmic vein is not that dilated, but you diagnose carotid cavernous fistula because this is not a direct fistula, it is an indirect fistula. The types include direct communication between the internal carotid artery and the cavernous sinus. And in this type, you see the cavernous sinus is very big and ophthalmic vein is markedly dilated. But if the communication is between a branch from the internal carotid and the sinus, then the manifestations will be less. And sometimes the communication between a branch from the external carotid and the sinus, and in this type D, the communication is between a branch from the internal and another branch from the external artery, the external carotid artery. Actually, this is the role of the interventional radiologist. And if you have the selective angiogram, you can identify the type of the fistula from these angiograms. But if you are asked about this appearance, you say that the right cavernous sinus is enlarged compared to the opposite side. It is homogeneously enhanced, and the superior ophthalmic vein is dilated compared to the normal superior ophthalmic vein. Then you are dealing with the carotid cavernous fistula. And this fistula can also be appreciated by MRI even without injection of contrast material by detection of multiple signal void vessels inside the cavernous sinus and the detection of marked dilatation of the superior ophthalmic vein. Then we came to the cavernous hemangioma or the brain cavernoma. This cavernoma was not appreciated in the era of CT, and it was usually missed. But after the introduction of MRI in the clinical practice, cavernoma is a well-known pathology and is diagnosed every now and then. Then what is cavernoma? It is a vascular malformation, and it is on the level of the capillaries. It is not a direct communication between the vein and the artery, but it is an abnormality at the level of the capillaries. That's why you can never see this abnormality by angiography. You can never see this abnormality by angiography. But you can see it by CT and you can see it by MRI with the classic appearance of this pathology. The most and very prominent symptom of cavernomas is scissors. And most of the cavernomas present by scissors, except the cavernoma occurring in the brainstem. The brainstem cavernoma presents by brainstem symptoms, but cavernoma in the cerebral hemispheres will present by scissors. This is the classic appearance of a cavernoma. It's a slightly hyperdense lesion, not surrounded by edema, exerts minimal mass effect on the adjacent structures, and if you inject the contrast material, it will not enhance. And this is the appearance of cavernoma in the T1 and in the T2 and in the susceptibility weighted image. The most important feature of cavernoma is seen in the T2 weighted image, where you got the low signal hemosiderin rim surrounding the lesion. This is the most important feature of cavernoma on MRI. Cavernoma on MRI may be of bright signal in the T1 and T2, but the hemosiderin rim is very important to identify this lesion and to diagnose it correctly. And cavernomas can be multiple, and there is a familial cavernomas where you got many cavernomas in many of the family persons. Then you see a cavernoma here and another cavernoma there. You remember that I told you if you want to see more cavernomas, you go to the gradient images or the susceptibility weighted image. And in this gradient image, you can see 4 cavernomas, other cavernomas. This one and this one and this one and this one. So the cavernoma on the CT scan will appear a slightly hyperdense lesion. It will not show significant contrast enhancement. and is not surrounded by edema and exerts little mass effect. The hyperdensity of the cavernoma is related to its content of blood and the calcium. Then on the susceptibility weighted images on the CT scan, you see two cavernomas. On MRI, you see, let's say, tens of cavernomas. And cavernoma in the brainstem is not presenting, never presenting by seizures, but presents by brainstem symptoms like diplopia, ataxia, and the sensory disturbances. And this is cavernoma in the brainstem, and you see on the T2 weighted image the characteristic low signal rim of hemosiderin. If you inject contrast material, it will not show significant post-contrast enhancement. Then there are some exceptions in the cavernoma, and these include, usually the cavernoma is in the range of 2 centimeters, but sometimes the cavernoma is large, reaching a size of 5 centimeters. Cavernoma is not surrounded by edema, but sometimes it may be surrounded by edema. Cavernoma does not exert a mass effect, but sometimes if it is large, it will exert a mass effect. Loss of the hypointense hemosiderin rim on the T2 weighted image will make many difficulties in the diagnosis of this particular lesion. Fluid level inside the lesion and the presence of peri-lesional hemorrhage if the cavernoma is starting to bleed. Then these are the findings that can be accepted in the diagnosis of cavernoma. And multiple cavernomas are seen in 20% of sporadic cases, and multiple cavernomas are seen in 80% in patients with family history. This is a well-known issue. Then we came to a lesion which is a very important. It's considered a normal variant, but it's a very important lesion. This is known as developmental venous anomaly, or DVA. Developmental venous anomaly is a vein that is draining a tuft of small veins draining normal brain tissue. So they consider this as a normal variant, not as a lesion. What happens commonly in the clinical practice is to diagnose this as an arteriovenous malformation. Then if anyone tried to embolize this lesion, he will induce brain infarction, because this is a venous venules draining normal brain tissue. So many of the literature beside this name, they put into brackets, leave me alone. Leave me alone means don't touch because you will induce an infarction in the brain. Yes. Then this is the characteristic appearance. The lesion is usually seen post-contrast, and the contrast enhancement is due to the very slow flow in this developmental venous anomaly. But sometimes you can see it in the T1, and also you can see it in the T2 weighted image. The lesion does not exert any contrast, any mass effect, is not surrounded by edema, is not a lesion in itself. It is just a developmental anomaly, and this vein drains normal brain tissue. Many times, cavernoma is associated with developmental venous anomaly. Cavernoma is associated with developmental venous anomaly. And cavernoma is treated by surgery. And the surgeon should do his best to avoid touching the developmental venous anomaly. This is very important in the treatment of cavernomas associated with developmental venous anomaly, and this should be reported clearly in your report that this cavernoma is associated with developmental venous anomaly, in order to avoid touching this developmental venous anomaly unless you will get a brain infarction. And this is the appearance of the cavernoma, but the DVA is not seen in the CT scan. Now we came to what's known as the aneurysm of the vein of Galen. Actually, the term of aneurysm of the vein of Galen is wrong. And all the literature nowadays says that this is not an aneurysm and this is not the vein of Galen. This is an arteriovenous malformation between the perforating arteries and the vein, which is a precursor for the vein of Galen. At the time of development of this abnormality, the vein of Galen is not yet developed. Then it is not the vein of Galen, it is not an aneurysm, it is an arteriovenous fistula between the perforating arteries and the precursor vein of the vein of Galen. But if you go in the exam and you are asked about this, you should say this is aneurysm of the vein of Galen. Otherwise, you ما أعرفش إيه اللي هيجرى لك لكن Then the fistulous communication between artery and this vein will result in marked dilatation of the vein, and this dilatation will be reflected on the sinuses where the vein is draining. And the vein drains to the straight sinus, and then to the confluence of the sinuses, and then to the transverse and the superior sagittal sinus. Then you will got marked dilatation, signal void appearance of the vein of Galen, of the straight sinus, of the confluence of the sinuses, and of the transverse sinuses. The main presenting symptom of these cases is heart failure. Heart failure because of the marked shunting of the blood from the arterial side to the venous side. It will affect the heart of these infants. Then you may got hydrocephalus because you know that the aqueduct of Sylvius is located here in the region of the quadrigeminal cistern. Then it will be affected, of course, resulting in marked dilatation of the ventricles. You can diagnose this even without contrast injection. You see the dilated vein is relatively hyperdense with marginal calcification, and you may feel that the sinuses are also distended. But if you have this MR venogram, then you can, I think this is a CT venogram. Then you see the marked dilatation of the vein and the confluence of the sinuses as well as the straight sinus. The last one of this group is the Moya-Moya disease. The Moya-Moya disease is a disease which results in progressive narrowing of the major vessels of the circle of Wills, including the anterior cerebral and the middle cerebral arteries. The narrowing will result in flow impedance, and this will lead the collateral circulation to open through the perforating arteries. And this is the appearance of Moya-Moya disease, and this is the normal appearance. You see the internal carotid, middle cerebral, anterior cerebral. But here you see the internal carotid, but you don't see other branches, and you see instead a collection of perforating vessels, which is known as the buff of smoke, like this one. And you got too many vessels, very small vessels, resulting characteristically in this appearance. If you see this, and you diagnose easily that you are dealing with a Moya-Moya disease, because of the obliteration of the branches of the internal carotid on the left, and also on the right side, you see only the internal carotid itself. Then frequently in the exam, you are confronted by this image, and you are looking carefully throughout the brain parenchyma, through the suprasellar area, looking for a certain pathology, but you do not see. The clue is in the suprasellar cistern, where you see extensive, numerous, very minute vessels instead of the middle and anterior cerebral arteries. Then you know that you are dealing with the moya disease. And if you have an MR angiogram, of course, this is not provided in the exam until late in the exam, after you realized that you did a big mistake. Then you show to you the MR angiogram and they said, okay, this is moya disease. And okay. Obliteration of the vessels of the circle of Willis may be secondary to neurofibromatosis, secondary to sickle cell disease, secondary to radiation, secondary to arteriosclerosis. Sickle cell disease is prominent in Saudi Arabia, for example, and I have been an examiner in one of these locations in Saudi Arabia, and I got a case of moya disease with me from Egypt. Then whenever I presented to the candidate, he answered immediately, this is moya disease. Then I know after that moya disease is very commonly seen in Saudi Arabia because of the presence of sickle cell disease. Then you should know that moya disease is a primary lesion or maybe secondary to other diseases like neurofibromatosis, sickle cell, radiation, and arteriosclerosis. Yes,